Thank you, Dr. Muhammad, for this intro. I hope that my presentation will be swift, and I just want to walk you through the different initiatives in the MOH and a special view on the FH. So we're going just to go over the familiar hypercholesterolemia overview, the registry overview, and what is the outcomes that we are going to analyze after the launch of the FH registry now for over 3 years. So before I start on these data, let's just imagine what is the importance of these registries. So the registries and the data of these registries, the lack of data in all healthcare systems or sectors really impacted the providers and the payers, and of course, pharma. So the providers will really be impacted of the lack of utilization of their data, because we do have multiple health systems. We have the lack of access to centralized, reliable data, and of course, the lack of standardization. So all of these would really impact the providers in getting such data. For providers, we lack the disease burden, because we don't know what is the certain diseases burdens in disease burden insights for us to have a decision that we need to look into certain diseases. Second is, because we don't have these insights, we are going to have a slow and low-informed policy decisions when it comes to certain diseases. And for pharma, depending on a high cost and time-consuming clinical trials to prove their products, and the lack of having such innovative contractors with payers really impact the pharma, and at the end, the access of patients. So the registries really would help us in monitoring prevalence and incidence. And what we look for is checking the effectiveness of new medications. We look at safety and tolerability. We would have a better data to reflect the burden of illness reflecting on our population. And all of these really very important when it comes to generating real-world evidence. So as Dr. Muhammad was stating that running a phase 3 clinical trial in their sites with patients with homozygous familial hypercholesterolemia, now our registry would really help us to identify the patients. We know what population, we know what segment. We have ready patients to enroll them in such clinical trials. So this is very important aspect when we have these drug disease registries. So again, the drug disease registries would really reflect or customize for the different needs of stakeholders. So physician would really have data on their patients, would really see their patient improvements and adherence to certain protocols. For the regulators, we would see the safety and efficacy. We would monitor the adherence of such practices. For the industry, would establish value. They understand the burden or the burden of the disease, the number of patients, the population that we are treating. And the payer definitely will limit the uncertainty, because by then, we already making sure that we could select right patient for right medication and having them through the unified process. So again, these registries would really identify the needs, the solution, and impact. So as I said, what is the need of certain data? Because every site, every hospital, every system has their own, let's say, systems that they cannot generate data that would support in different decisions. So once you have this centralized, unified, you would really get a good data to guide you in different decision when it comes to different disease areas, because this would really reflect your population. IFA in Italy, they go with pay for performance, and once they launched or worked with disease registries, they conducted even more because they know their patients, they know their population, they understand the disease burden, and they can get even different negotiations with the pharma in order to get, let's say, either prices or different agreements with them and different outcomes. And this is exactly what happened with us in one of the rare diseases. We generated our report, and for the extension of the second, or the extension of the 2 years after the first contract, we changed the endpoints, because now we know our patients, we understand the disease and how our patient is, the medication is really reflected to their conditions. So we changed different endpoints and different scores based on our evaluation or the data that we generated in the real world setting. So this is just to give you what activities and what registries that we are currently having. So we have more than 8 registries, and one of them is the FH. Actually, FH was the first registry that we started with in 2017, so or 2018. So one of the applications that now currently we are reflecting on, whenever we have new medications that we are reviewing, for instance, the new medication coming for FH. So now we have a better understanding of the population. We have a better understanding of the type of patient that we are dealing with, different sites. We now have a better view on the patient flow for FH. So we would have a better decision making when it comes to the evaluation of certain medications. And would help us even to get different negotiation with the pharma, depending on the initial report that we generated for the past 3 years. So I will not go in details in that, because this was covered by Dr. Al-Judai. I'm just going to mention that why did we have the familial hypercholesterolemia registry? Why did we go for monitoring patients and see how will they react? Because I know that population is very large population. They are not rare diseases like a couple of hundreds, no. And the medication is really expensive. And I need to know to monitor those patients, because we are looking into a better outcomes. So this needs to be really reflected and calculated in a way to justify even investing even more on these population and certain management of those patients. And then we went through different agreements, financial outcomes when it comes to FH patients or outcomes. Okay, so this was the report from the GCC registry for FH. So basically, they were talking about that Saudi Arabia has the highest prevalence of ACS, and the number of patients with uncontrolled LDL was estimated to be about 29,000 with FH, and about 300 without FH in Saudi Arabia. Now, and this reflecting the effect of PCSK9 on the patients, resulting in reduction of 28% in cardiovascular events and patients with FH, and 23% with patients with ACS. So now we are trying to, or we are reflecting those insights to the actual patients in our registry, reflecting the percentage of patients with different type of FH, whether familiar or homozygous or heterozygous, and how are those patients, the medication is affecting their LDL in certain levels. What are the medications that were coupled with? How is the adherence is moving toward those patients? So the reasons or the objective of having these registries is, first of all, implementation of any value-based agreement. So it needs to have a platform, a controlled platform for us and for the pharma industry later on to generate these reports and get the outcomes or rebates for such agreements. And then most importantly for us is generating real-world evidence, of course, and then ongoing assessment and treatment for patients. So when we usually review these cases with our steering committee, we see that some physicians identify those patients as an FH, but yet they did not request for, let's say, upscaling of medication. So we tend to either, I'm not sure whether it's not understanding that this medication has been added, there is a guidelines, we don't know with those gaps, but we identify them and we act on it, communicating, understanding sites that I need to focus with, who is the, let's say, regions that I need more training and more education, and so forth. So it's good to put faces on the team that's working in the FH that we have dealing almost daily. So the project is owned by the Therapeutic Affairs. Our medical leads, Dr. Mohammed Al-Harbi, our endocrine, Dr. Adil Dash is our cardiology, and then we have Lubna, we have Maram as the registry operation managers, and then for the coordinator in the Ministry of Health is Daad, and then site coordinators that facilitate even the communications, so, and Isra, Anfal, and Muhammad Bakri. So it's good always to see these faces that we are daily in communication with. This is just a screenshot of the digital platform, state-of-the-art platform that reflected whatever the guidelines that has been approved by the Ministry of Health and make it a digitalized flow for certain indication or information that needs to be captured for patients. And then the diagnosis of FH, we, of course, went with the Dutch Lipid Clinic Network in highlighting or categorizing those patients, whether definite, probable, possible, or unlikely, based on the scores. And then of these patients, and then pediatric patients as well, so we have adult and pediatrics as well. And then these are just some numbers on how we are moving. So we have now, this is last week update. So this week we are over the 6,000 total of patients that has been already captured in our registries. We have 51 sites across the kingdom that have been trained and launched these sites. Now, the selection of these sites need to have two components, having a consultant endocrinologist and a consultant cardiologist. Now, one of the gaps that we analyze within the steering committee is we have different or multiple sites that does not have this. So now we are injecting the virtual clinics to help in that matter, having a consultant with us and trying to bring the patient without making them travel to just see the physicians or the consultant. So we are now injecting our patient into the virtual clinics. This is just to give you the utilization of the medication. It's about half and half, 106 consultant endocrinology versus 96 consultant cardiology who are prescribing PCSK9. And then these are, again, the flow of the approval. So this information is being entered through the platform, and it's automatically, if it reflects the eligibility criteria, then the patient gets listed. If not, then we are just following up the patient based on the eligibility criteria. So one of the activities that we do, not just having these events or these monthly meeting with the regions, we tend to release a newsletter that emphasize the guidelines, the eligibility criteria, the name of the medication, the dosing, and then we had some sort of engagement from the regions just to show certain KPIs in different regions. What is the highest, let's say, number, the highest clarity of data and engagement, and this is weekly newsletter that's generated from the FH official email at the MOH. It's not moving. Can you? Okay, sorry. So, and then the other medication is for homozygous, the lometabide as well. We had concluded multiple training for the clinical nutrition, because this is one of the components for those patients to be entered in order to be eligible to have, to be prescribed lopetamide, because we need to make sure that they are consuming less than 20% of fat during their meal plans. So this has been done, created, the format is being electronized and entered into the registry, so we can make sure that the patient already is following the pathway of the management for homozygous. And exactly, this is the same criteria or the guidelines of patients with homozygous. How should they start being diagnosed, and then different steps until the patient's being eligible for lopetamide. Now, this is what we are, inshallah, going to release. And this is my last slide. The different numbers of patients based on their, let's say, whether they are homozygous or heterozygous, the reduction of LDL, the reduction of MACE, the reduction of, or their adherence as well. We calculated their adherence because we need to do the blood test every 3 months, and we have 1 month grace period just for us to be sure that the patient would get enough time for us to, for him to do this test and schedule with the hospitals. So by region, by site, by gender, and by age, of course. So this is really detailed reports that we generate, and for us to understand what is the LDL reduction that we are facing. So in real life, understanding that it is not a clinical trial, it's a real world evidence, and it's a real world setting that reflects the health system at the Ministry of Health. And by that, I ended my slide. Thank you so much.